picture here. You can see it even better when you're looking on your own PowerPoint pictures on your computer, but look at those fingers. Look at that left index finger. Gout is supposed to be exquisitely painful, and you can see why. So let's talk about that. That's the last form of arthritis we're going to talk about. All right. Gout's discussed on page 237 in the textbook and in the ATI book on pages 247 and 248. And gout is a particular type of arthritis in which an overabundance of uric acid builds up. Uric acid is a byproduct of our body when we metabolize protein. And everybody has a uric acid level. It's found by drawing blood, and the healthy person has uric acid in a very specific range. It's somewhere between 3 and 7 milligrams per deciliter. So not, a whole lot should be found in your blood. If you have too much, either because you are producing too much uric acid or you are not excreting enough, then crystals can form in the blood. And just the way crystals in the urine can lead to kidney stones, crystals in the bloodstream seem to want to head for joints, small joints that get a lot of pressure on them, like fingers and toes and elbows. The symptoms are swelling and edema from fluid buildup, a lot of heat. Not that anybody with gouty joints is going to let you touch them without a whole lot of resistance, because the pain is severe. So gouty arthritis forms when this uric acid leads to crystals that collect in one of your joints. And this poor person in the prior slide, as you can see, has had them build up in their hands. Many times the big toe is a favorite place for uric acid crystals to form, and sometimes the elbows. Then if you can find a picture of the crystals, the gout crystals, they're very long and sharp. They look like those stalactites that hang off the roofs of caves. I mean, you don't want them in your joints. So we have two particular drugs that we're going to talk about. One is a drug called colchicine, and then the other is a category of drugs called uricosuric agents, and that prototype drug is called allopurinol. Now, colchicine is a drug that does not prevent uric acid from being deposited in the joints. I mean, it does prevent it from being deposited in the joints, but it doesn't keep it from being collected in the bloodstream. So colchicine is going to relieve that pain in the first acute period of gout. So a person is supposed to keep a supply on hand, take it at the first sign of pain in the joints. So it doesn't reduce that uric acid in the body, either keeping you from producing too much or making it more of it be excreted, but it does try to keep it out of the joints. These are oral meds, and somebody with their first gouty attack hopefully is going to have a supply that they keep at home, and as soon as they suspect they might be having a gouty attack, they need to take that colchicine. The other type of med they need to take is some sort of uricosuric agent, and our prototype drug is a drug called allopurinol or Xyloprim. And if you look on the bottom of page 237, we've got the Xyloprim, and then we've got a drug called Uloric, which is another kind, febuxostat. How's that for a name? This does not prevent pain. It doesn't have any analgesic properties. It's not going to relieve the person's discomfort, but they take it as a preventative to reduce their uric acid level and to help prevent further attacks of gout. The person can take it orally. If it's the Xyloprim, And it can be given IV if it needs to, too. So bottom of page 237, you can read about these drugs and the nursing implications. There are some other drugs that a person might end up taking for comfort. Sometimes they might get steroids. They can take NSAIDs for relief of the discomfort, but these particular drugs are specifically given for gout. So you can read more about colchicine on pages 247 and 248 of your ATI book. So it's for treatment of pain with acute attacks. So colchicine is acute. So I wish it were AACC, but it's not. It's ACCA. So colchicine is used for acute attack and can be given for gout that hasn't improved pain-wise with NSAIDs or something similar. Main side effects you're going to see are GI problems, some abdominal pain, nausea, vomiting, and diarrhea. If that progresses to severe abdominal distress, GI pain, a person should stop the med and notify their healthcare provider. In very rare instances, it can cause suppression of bone marrow, thrombocytopenia, where you've got platelet issues, and it can cause muscle breakdown, rhabdomyolysis. Once again, this is a drug you shouldn't take grapefruit juice with. You know, poor grapefruit juice, it just can't catch a break. It interferes with the metabolism of lots and lots of drugs. The uricosuric agents like allopurinol, they increase the excretion of the urate salts in the urine. They block the kidneys from being able to reabsorb these urate salts. And so they keep you from building up more uric acid in your bloodstream. And so they help prevent it from getting higher than that 3 to 7 milligrams per deciliter. So it's used to reduce the uric acid levels in patients if their kidneys do not excrete enough to get rid of it. Now, as if the great big huge sore joints weren't enough to give you the idea you have gout, you can have a couple of tests to confirm gout. They will draw your blood, and if your uric acid level is greater than 7 milligrams in 100 milliliters of blood, you got gout. They can also do a 24-hour urine test, and they can see if you have less than 800 milligrams in that 24-hour collection, less than 24 milligram or 800 milligrams of uric acid in your urine. Once again, you have gout. They also can take a needle and aspirate that joint and look at what's in that fluid. Doesn't that look tempting? If somebody came at my joint that looked like that with a needle, I would, yeah, that wouldn't happen. So people pretty much know when they have gout, and they need to prevent it with a uricosuric and make sure that they keep some colchicine on hand to take when the pain and swelling starts. Uricosuric agents, you can look for more information on page 237. But side effects for the allopurinol, headache, rash, nausea. You might have increased gout symptoms at first as your body adjusts to changes in the uric acid level. Now, stronger adverse effects are pretty rare. You can get kidney stones, but oh look, liver and heart failure or stroke. But like we said, those are really, really rare. Drug interactions. Allopurinol is prevented from being absorbed properly from aluminum antacids. So you don't want to be popping like Tums and any other drugs that contain aluminum. Allopurinol also interferes with the metabolism of Coumadin, but hello, what doesn't, right? Febuxostat can interfere with chemo drugs. So you cannot use them in addition to chemo drugs. Now, allopurinol is sometimes used in cancer patients because when you have bone involvement with cancer, and there's a breakdown, that increased bone breakdown leads to increased protein metabolism, which causes your uric acid levels to go up. So sometimes along with chemo, a person will be taking Xyloprim, but they're not going to take the febuxostat like they would with gout because it doesn't go well with the chemo. You want to read page 238. Talk to the patient and family about preventing attacks. Tell them when to take their medications. They want to watch their diet. You want to cut down on lots of protein. This is very commonly seen in people with high meat intake, high protein intake. So it's recommended that the person changes their diet somewhat. Instead of eating a lot of fish, maybe take fish oils to get the benefits. Increase fluids, fruits and vegetables. They should self-monitor their urine and stool. They should be taught when to contact the health care provider, how to take the colchicine when they get the first signs of gout, common drug interactions, and you want to avoid foods with purines, those amino acids, such as tuna that breaks down into uric acid. Like I said, the MD can also aspirate fluid from a gouty joint. Does not sound fun at all, but sometimes they'll take out the fluid and then inject it with a long-acting steroid, and that can help. And then, like I said, NSAIDs for discomfort. And that's it. Look at that. Pharmacology class is over. That is your last lecture. So I will let you move on with things, and the final's coming up, and I haven't made it yet, so I can't tell you how it's going to be, but I've enjoyed the class. All right, we'll stop here.